to this evening. I promise you would not be disappointed. So my name is Jaiye Olaleye. Many people just call me Jay because it's easier, but I'm happy to be called by my full name, by my mini name, which is Jay. But I'm a GP, I'm an NHS GP, and I work in Oxford. But I do also work locally as one of the primary care gynae women's health GP in the primary care gynae service for NHS. And that's where I work with Dr. Biggs. We work there together. I also have other roles locally. I'm an associate non-executive director at the University Hospital College, UATW in Coventry. I have other roles, but I'm just limiting my conversation this evening to my women's health role as a GP and also as a general GP. So I'm very, very excited to talk about this because it's up my alley. And the title tonight is, as you know, it's not all about HRT when we talk about menopause. There is lifestyle medicine. And I do have additional qualifications in lifestyle medicine. So I was very excited to have this conversation with you. So please feel free to ask questions as we go. But my talk hopefully should last for about half an hour, and then we can have a lot of time for questions. This is all about Verity. I've told you about myself already. So tonight we'll be covering quite a few things. I must apologize in advance. So perhaps, yeah, some of the slides are mine and some of the slides are Verity's. So if you see that there is a different color for each slide, please just accept it as it is. It's meant to be interactive and it's meant to be quite interesting topic. But overall, we will be covering some definitions. We would be covering some symptoms of menopause. We will be talking about the diagnosis, and then we will talk about the alternatives to HRT generally. And we will go a bit more into all of that. So for many of us, we know what the definition of menopause means. Is that correct? Please write in the chat. If you're not too sure, I can go through the specific definition of menopause. But I just wanted to talk a bit more about perimenopause, which is the time leading up to menopause, as many of us know. But for some women, that period of time can last any time between 4 to 10 years. So that means that for a woman in her early 40s can begin to experience some of the symptoms very early. And some of the symptoms can be very, very vague, very vague. And it's going to take a lot of, sometimes your intuition, your gut feeling, sometimes a lot of tests would have been done before you come to the diagnosis. And not many women like to accept the fact that they are in that stage of life because they don't think they should be. Going on very quickly to postmenopause, which is basically the period after a woman has stopped having her period. But also I want to bring our attention to the primary ovarian insufficiency, or what some people call premature menopause. And that's menopause before the age of 40. And I'm aware that this group of women sometimes suffer for such long periods of time before they can actually have their diagnosis. Not for any reason, but perhaps as healthcare professionals, we are maybe not recognizing this can happen sometimes before the age of 40 for women, especially women who have had adverse childhood experiences. They sometimes go through menopause very early compared to their colleagues. And then there is the induced menopause due to chemotherapy, surgical menopause, or other types of treatment. So it's just a matter of raising an awareness. So the average woman comes to you, talks about a number of different symptoms. You should begin to think, okay, could this be something to do with our hormones? Obviously, it's not just the female health hormones. There are other hormones involved. And that might help you decide when you want to do some blood tests or whether you just want to kind of explore what she wants or what she wants to prioritize. Now, I think it's really important for us to know what we perceive or what our stories are, or what we think the stories out there is about menopause. And when I give this talk, I usually like people to write in the chat when you hear the word menopause, what comes to mind? And it's really important as healthcare professionals because sometimes we are blindsided by these things. And even I, as a women's health GP, sometimes I'm blindsided. Um, and I feel it's not fair because most women would be transition. Thank you very much, Shanaz. HRT, definitely. What else? Anybody else? When you hear the word menopause, what comes to your mind? Or perhaps what have you heard growing up? Or maybe what do you hear at work, or perhaps in your culture or in your communities? It's really important. Some communities, some cultures don't even have a word for menopause. Hot flushes, mood swings, definitely, Debbie. Um, for example, I'm from Nigeria. My culture, my language is Yoruba. We don't actually have a word for menopause, so it can be really difficult for women to definitely variable experiences to actually brain fog. Definitely, Sophie. Now, a lot of this, yes, period stop. Sometimes that's what some people describe in their culture. They just say, yeah, they actually say it in a sentence rather than a word. Oh, definitely, Emily. The psychological symptoms of menopause is intense. And I say it as somebody who has experienced some of it before. So the purpose of this slide is just to let us know that these beliefs can shape how women suffer and also shapes our perceptions as healthcare professionals about what kind of help we want to give people. Some people believe that when women come, all they want is HRT, which in actual fact may not be the case. And that's where our talk is going to be going to this evening. And we all know that menopause is both a biological and a psychological transition. I don't think it's fair to allow women to white knuckle their way through this transition without any help for a number of reasons. We've talked about the biological changes, the metabolic changes that happen, which increases their risk, but also the psychological changes, which also increases the risk of suicide in a lot of women. I think sometimes that's what drives my passion because you see a lot of women and we have a lot of, I mean, if you look at the office of the National Statistics, it tells us that women in midlife have higher suicide rates. Now, whether or not this is all due to the biological transition or whether it's due to other causes is difficult to tell. But I must say here that 80% of women would experience symptoms of menopause, and a quarter would have severe symptoms enough to impact their life, enough to impact their relationship. We know that the highest rates of divorce is around after the age of 50. And who knows whether many of the women who experience divorce or suicide, perhaps if they get help at the right time, could have prevented that happening. And we know that it affects work as well. And when we talk about the impact of life, we talk about the physical health, we talk about the emotional health, intellectual. A lot of people have cognitive issues, and that can affect a lot of women's self-esteem, their confidence at work. Now, we talked about the longer term implications. There's a higher risk of a lot of chronic medical conditions in this time, diabetes, hypertension, obesity, then not to talk about the bone health as well and the cognitive health as well. Now, all of these factors can lead to quite a poor quality of life. So a lot of women out there probably suffering a lot more than they want to tell you. So it's really important as healthcare professionals that we explore all of this. They may come with very, very vague symptoms, but taking time to look at the impacts it's having would actually help you to draw out a lot of information from women. Ask about their work, ask about their relationship, ask about their life, ask about their motivation, ask about their motivation about life, their confidence, their self-esteem, and a lot of this information will begin to pour out. So why do we talk about, alternatives? Because out there, everybody thinks, yeah, every woman wants HRT, but actually, some women prefer not to have HRT. Some women have medical conditions that means that it's contraindicated. And some women would have side effects. So some women would have started HRT but would have to stop because they have had side effects. So what do you do if that happens? And that's what we'll be talking about tonight. Um, we already know about most of the symptoms of menopause. There was a study I was reading that in one woman, they may have like more than 4 different symptoms, especially in perimenopause. Um, but again, I want us to think beyond hot flushes, or because symptoms can vary from one person to the other. And that's why it's important to not to have just that one service or one treatment that fits everybody, or some will sail through, but for others it's life changing. Like I said before, it can affect their work, their home life, and a lot of other things. So these are all the symptoms. And just before I forget, we would be sharing the slides afterwards. So if there is anything I'm not going into, it's because you're going to have time to read it through. And as healthcare professionals, I want to believe that we already have some idea of some of the symptoms. So I'm not going to go through all of the symptoms on the slide, but I want to in particular talk about, the behavioral changes that can happen. And some women feel it quite a lot, and it has a huge impact on their work and their family relationship. And for a lot of women, when they come, they find it easier to talk about the physical symptoms. But what if there are no physical symptoms? What do you do? And that's where you begin to find some complain about tiredness, some think that, they're teary, they're anxious. A lot of women come to talk to me about their anxiety, that I never used to be this way before, constantly worrying about this person or that person. Or sometimes they just have a shorter fuse, they don't tolerate things. Once you're talking to a woman for more than 10 or 20 minutes, they just kind of lose interest in what you're talking about. And a lot of muscular joint aches, stiffness, swelling, pins and needles, um, so many different symptoms. So it's really important to kind of draw this out of women. Now, these are all the kind of graphs that you will see hanging around. And I like the one on the right side in particular because it shows you the purple mark, which is the estrogen kind of nice and normal, um, up until menopause, where perimenopause, where things begin to drop and change. But you can see for a lot of women, the dotted orange one is the progesterone, which actually drops quite a bit before the estrogen changes begin to happen. And for many women, that's where they begin to get the symptoms of anxiety, because we know progesterone has a calming effect on the brain, or they begin to have problems with their sleep. So this period of time is very crucial. And I always say it's the warning sign that the bigger things are about to happen. And this is the time to begin to intervene as much as you can. So to make a diagnosis, again, a lot of it is in the history. Try to draw out as much as you can. Not many women will be forthcoming. Some prefer to think of it as a physical symptom rather than a psychological symptom. And some women obviously might be on hormonal treatment. So even when you're trying to do some blood tests, you may find that actually the blood test is not reflective of what they are going through. So really, it's all in the history for a lot of women. If you do have women who are younger than the age of 45, 44, you can do blood tests to rule out, and even over the age of 44, to rule out other factors, things like their thyroid, their iron levels, their vitamin levels, all of those things all matter as well. But for the FSH, um, it can be quite misleading over the age of 45. So preferably not to do it for women. And that's what the guidelines tell us to do as well. But you can do other blood tests. Now, question is, when do we begin to think of referring women to specialist services or menopause services? Personally, I think that when you're not too sure whether HRT is appropriate for them, and you'll find a lot of women in this category, whether they have some kind of epileptic conditions or they've got lupus or they've got PE, you may not feel very confident about prescribing hormonal therapies for them. So you might need to get them to see a specialist. Obviously, when there's a history of cancer and you don't feel very confident about it, then get them to see a specialist. Perhaps you have even tried them on HRT and it's not really working and you're not too sure what to do and you don't want to be faffing around with all the different types of regimes. Please refer to specialist services or when there are side effects as well. So number of cases in the primary care gynae service, we see quite a lot of women who have complex menopause history. Now, obviously, there are goals to alternative care, but the bottom line is that you want to be able to counsel your women, the ladies who come to you about all the different forms of treatment available apart from HRT. HRT is the first line treatment. I mean, I think lifestyle medicine is also one of the first line treatment. But for some women who don't want HRT, it's really important to give them that hope, at least something they can do that can help to improve their symptoms. Okay. Now, there are 4 categories, I think, or generally for non-hormonal treatment. I mean, the general guidelines tell us that lifestyle, HRT, and CBT, they are the 3 main treatments for women in this age group. But when you look deeply, and I know a lot of our women actually look online, TikTok, Instagram, they get all their information online. And if you want to categorize all the kind of treatments available, I'll put it as 4. There's the lifestyle modifications, the complementary therapies, the medications you can prescribe, and herbal remedies. Now, lifestyle medication, at the end of this, I share 2 very interesting articles that have just been written in the last 3 months. One from the International Menopause Society, which is really very good if you really wanted to find out the evidence behind lifestyle treatment for HRT. I would really recommend that paper. It's a very good paper. It really outlines all the 6 pillars of lifestyle medicine and the evidence behind it, especially when you want to treat menopausal women. I share the link for that paper afterwards. But we definitely know that some behavioral changes would help the symptoms, we all know this: light clothing, avoiding spicy food, avoiding caffeine, stopping smoking. Those are all, you would say common sense things, but some women don't realize that some of these things actually contribute to some of the symptoms that they are. So it's always quite good to at least talk about those things with them. The physical well-being side of things involves exercise. We know the benefits of exercise goes beyond just weight loss. It helps their metabolism. It helps strengthen the bone. It also helps the mood as well. So it's really important to talk about not just the cardio kind of exercises, but the relaxation type of exercises as well. There's a lot of evidence behind yoga for hot flushes, for example, Pilates for strengthening the core muscles, especially the pelvic floor muscles that become very weak in menopause. And again, all of these have an impact on the mental health. Nutrition is very important. Earlier on today, I was talking to a lady who was having hot flushes despite being on HRT, and I was asking her what time she eats too and what is her dinner like, and she was saying that she normally has a steak dinner. I said, you know what? The amount of energy your body is going to be using to break down the protein you're eating after 8 o'clock is so high that you're going to have a lot of hot flushes, night sweats at night. So if you're going to eat a high protein meal, because I know there's a lot out there about protein, high protein, you better eat it earlier on in the day rather than later at night. So that is really important. The timing of meals, there's a lot out there about intermittent fasting or time restricted eating, which again can be very helpful. And it's all about kind of timing things into your own natural cycle or your own natural rhythm, which really helps. And there is a lot about the gut microbiome, which supports a lot of other functions, the immunity, the mental health. So there's a number of interesting things you can actually talk to women, especially women who are not going to use HRT. Don't make them feel left out. I think it's really important to look at all this information. Vicky,
Hi,
time
yeah,
up.
sorry to interrupt. Can everyone see the slides? We've had an email from one of the attendees, and they're having problems viewing the slides. Is everyone else okay? If you could just give me a thumbs up.
Okay, thank you, Debbie.
Yeah, yeah, all fine. Okay, no worries. Thank you.
Okay, maybe they can log out and log back in.
Yeah,
Okay,
no worries. Thank you.
we will share the slides afterwards. And Ali says she can see, quite a few people can see. Now, a lot of women talk about cognition and brain fog. And that can be, I find there's a lot of contribution to brain fog. Um, and the main thing here, especially if you're not going to be going down the use of HRT, I think is sleep. When many women sleep better, their brain fog clears up a little bit better. And also the kind of exercises they do to help their mental agility as well is really important. But also, it's about modifying all the other risk factors, diabetes, hypertension, things like hearing. You may not realize that some women, especially in this phase of life, begin to have hearing problems. So they're not getting enough input into the brain as well. So it's important to address all of those modifiable risk factors. But I also would recommend social interaction. Menopause is not a time to withdraw into yourself. It's a time to actually connect and also find good courses that you can support. The more interaction, social interaction you have, the better it is for the brain. Partly because it releases good hormones, feel good hormones that kind of help to balance things out a little bit better as well. Now, with the prescribable pharmacological options, there are quite a number of them actually. And I'm not too sure if you're aware, but we'll try to go through them. I can see my time is far gone. I have only 5 minutes. But I want to touch on maybe oxybutynin, for example. Oxybutynin is actually very good for hot flushes. And I have a woman who has breast cancer, has really bad hot flushes that we just tried the oxybutynin for her, which is working really well. So that is an option. Now, I find that when I talk to women about SSRIs and SNRIs, they're not really keen. And that's understandable because a number of women, have that feeling that they're not depressed and to be honest, the type of depression that happens in menopause is not just the normal type of depression. It's a lot of it has to do with the impact of progesterone on the brain. And also obviously the lack of estrogen as well, which is all connected with serotonin. So it's really important to help women understand this and that there are medications they can use, which coincidentally can work for hot flushes as well. There's the gabapentin, there's clonidine, there's mirtazapine, and there are these newer medications, the NK3 antagonists, which is not yet available on the NHS, but it's available to some patients privately. I will talk about the vulvar conditions. A lot of women can act, again, in my clinic today, I saw so many women with vulvar conditions, and it ranges from itching to recurrent UTIs to urinary incontinence to dryness to pain during intercourse. And it's a matter of encouraging them to try the estrogen cream, even if it's just for a short period of time, to see the impact it can have. There are a few other options. There's the ospemifene, which is a tablet. You know, the DHEA pessaries as well. I think there's another slide that goes really into that further down the line. Now, the next one I talk about is the complementary therapies. CBT for menopause works, and there is evidence to show that it actually works for hot flushes. It doesn't reduce the frequency of hot flushes, but it reduces the impact it has for a lot of women. So I always encourage women, if once you start HRT, the next thing is try to find some therapy with a qualified therapist as much as possible. All of these things help. They do matter when you combine all these treatments together. There is good evidence behind hypnosis, would you believe, and acupuncture as well. And we all know mindfulness has a lot of benefits anyway for so many other conditions. So I always encourage women to explore therapy, whether or not it's CBT or acupuncture or a class they can do for mindfulness or hypnosis. It's always very beneficial. Now, herbal remedies is a minefield. um, I don't go really into it, but I know that there are few ones I recommend for my patients. And the top one for me is vitamin D. Again, for their bone health, but also for their immunity and for their mood as well. I always recommend it. If they can use it, especially in the winter months, I always recommend that they get some of those tablets. Magnesium is one of those that we know has a lot of impacts for sleep in particular. So again, or even for things like migraine, some women begin to get migraine a bit more during especially in perimenopause when the hormones are fluctuating. So those ones I think are quite good, and I would recommend it, especially if they don't want to go down the route of HRT. Um, Now, a number of these, I will quickly go on to vitamin E. And I tend to recommend extra virgin olive oil because it has a good amount of vitamin E in it. Sometimes I ask women to take like 2 teaspoonfuls before they go to bed at night. And it does make a lot of difference for their sleep, but also for their joints as well. So there are little things. Now, a number of all these other ones, gosh, there is a lot of information out there, but there isn't a strong evidence behind them. Some people would say it works for them, others would say they don't. There are a few emerging supplements which are out there: ashwagandha, lion's mane. I'm sure some of you have heard of those before: rhodiola, ginkgo, glucosamine. There's a lot out there, but one has to be cautious with all of this. I mean, if you go onto women's health forums, a lot of people will say this worked for me, especially lion's mane. It's helped their, cognition. It's helped their mental clarity. I would be very wary about prescribing it, but obviously, if a woman wishes to try it, then you just have to help them understand that there isn't a strong evidence behind it. Some of these things are natural, but we don't know how much. We don't know how pure some of them are. We don't know how mixed they are. There's not a lot of evidence behind it as well. Evening primrose oil doesn't have a lot of evidence behind it, unfortunately. But yes, some women believe that it works for them. Whatever you do, I think you should give them that opportunity to maybe try one thing or two things at a time, but give time, at least 2 to 3 months, to see if it works before they give up. So we've talked about the medications already. Bear with me. Now, the other treatment, especially for skin, you hear a lot about collagen treatments, and some women actually use collagen powder. Now, again, I tend to be very careful about all of those kind of things. I believe if you have a good diet, especially if you reduce the processed, ultra-processed food in your diet, and you use things like olive oil to cook, then you will find that a lot of this has a lot of benefits. But I know there's a lot of people who talk about collagen. But again, at the end of the day, every woman would have their own wishes. They would want to explore, they want to read. Yours is there, you're there to guide them as to what the evidence is behind some of these treatments are. We've talked about some of this, reflexology, Reiki, sound therapy. A lot of this is just to help relaxation. This is all about, the vaginal treatments available for women. I don't know if you can see this one. We call it E-string. This is one of those treatments that have the vaginal estrogen, and some women can have this. It's actually something they can put in themselves, and they can still have a pessary inserted as well. But the vaginal estrogen, there are about 3 different types. There's the low dose one, which I think is the Invagase, which is got 30 micrograms. And there's estriol, which is about 50. And there's another one, which is higher, with about 1. Again, some women might be a bit cautious. You can start with the lower strength one and then gradually move up, depending on what kind of treatment. And it does have a lot of help, especially for the genitourinary symptoms of menopause. Now, this just, again, you will get this, like, this is too tiny to read, but this bottom line here is to reassure you that 1 tablet of oral estradiol is the equivalent of using vaginal estrogen pessary for a year. So the amount of estrogen in the vaginal pessaries are actually quite tiny, not enough to cause any significant problem at all. And that's why more and more, even women who've got breast cancer, and if you're not too sure, you can always write to their oncologist to confirm with them, are they happy for you to use this estriol treatment? And we already have the backup from BMS and RCOG to say that it is safe in breast cancer, women who've got breast cancer. Okay, so the key takeaway tonight is alternative treatments or other treatments apart from HRT is an emerging field. There are some small studies that are low quality. There's not a lot of evidence, but at the end of the day, there's no one size that fits every woman. Really important to hear from the woman what their priorities are, what they wish to try, what questions they have, especially if they've read an article somewhere. Let them bring it, have a sit down, talk about it with them. If you're not too sure you can, handle it, then refer them to menopause services, which hopefully would help the women as well feel like they're being seen, they're being heard, and they're being listened to as well. Now, this slide has the two really interesting papers, which I think every healthcare professional should read. And they're very recent, all in the last 2 months. And one of them is the role of lifestyle medicine in menopausal health. And it gives a review of the non-pharmacological interventions. And the other one is the alternatives to hormone replacement therapy. And you can, like I said, I will share this afterwards so you can have a look at them. I think that's it. Thank you very much.
Now the floor is open to you guys for any questions. Yes, Elaine? You're on mute.
Apologies. Thank you. That was a very interesting talk. Could I please ask about the risk of osteoporosis after the menopause, sort of comparing if you take HRT versus if you don't?
Now, that depends on a lot of different factors. So, for example, and that's why I keep saying one size does not fit all. If you look at the woman in front of you, you want to look at her diet. You want to look at the risk of malnutrition. You want to look at her family history. I know a lot of women will kind of avoid dairy products partly because of the intolerance. You want to look at their medication history. Now, the risk is always going to be there. There's a number of graphs which show actually the difference between men and women and how the risk of osteoporosis kind of, quite obviously different from men and women at that age in menopause. Now, the advantage, obviously, with HRT is that it would help to reduce that risk. Now, I wish I had a chart to show you, but I think there is a graph somewhere which actually shows what HRT can do to help to reduce the risk of osteoporosis in women who use it. But like we said, not every woman would like to use HRT. So the question is, what if a woman doesn't want to use HRT? How can you help them reduce the risk of osteoporosis? And that's where I feel the lifestyle intervention really matters for every woman. They should be doing strengthening exercises, bone strengthening exercises, whether or not that's jumping or skipping or some weight bearing exercises to really help to strengthen their bone, move their muscles together. Look at their diets and make sure they have calcium and vitamin D, or not, they should be taking supplements as well. So those are really important things to extract when you're really talking to them. Look at their history, and all that way you can then base your recommendation. But the risk is definitely higher for women who are not using HRT compared to those who use HRT.
Thank you very much.
I hope that answers your question.
Yeah, thank you.
I've got some questions in the chat for you. What dose of vitamin D do you suggest, and what magnesium dose, and any calcium?
That's a very good question. I don't think I have this specific. I think there was one of the chats here actually. The magnesium one, I can't tell you because I don't often go down that line, but I can always find out for you, Debbie. Because I have a nice book, two books actually. There's one book I have called Natural Menopause, and there's another book by Lara Briden. I don't know if any of you read Lara Briden's books. That talks a lot about all the different types of magnesium. The vitamin D, I would always say use the low maintenance dose. And it varies. I can't remember it from the top of my head. I think it's 10. But if you go to the pharmacy, the low vitamin D dose should be absolutely fine, unless you do a blood test, which actually confirms you have vitamin D deficiency. And that's why sometimes I always recommend some women, especially over the age of 45, to still have some blood tests, because some of the symptoms could be due to vitamin D deficiency. And in that case, they need a high dose, really high dose of vitamin D, which is 20,000 units to use. But otherwise, I'm happy for them to just use the over-the-counter low vitamin D supplements.
Thank you. To answer your question, yes, we're happy to share the slides, and we will send those out in PDF form. Another question for you. Which websites would you recommend for patients to educate themselves about menopause? Patient.co.uk, Balance app, Menopause Matters, anything else?
Those ones are really good, actually. But I find the British Menopause Society does a really good range of leaflets for women. As for example, I was reading the one for epilepsy and HRT, and they have another one for lupus and HRT. So the British Menopause Society, I think I trust them a bit more when it comes to patients educating them. So they have a very good one for testosterone as well. So the idea is that they break down most of the concerns women have, and they actually create leaflets for that as well. You're welcome, Lena.
Are there any more questions from anybody?
And on the slide here, this last slide, which we would share, has got a few other, I think the same as yours, really.
Here's one for you. Do you have any thoughts on testosterone?
Yes, I do. Well,
That's
testosterone.
not me asking the question, that's in the chat.
I know, I can see it. I can see Sophie. Sophie, thank you for that question. Yes, I do have lots of thoughts about testosterone. I think it's a very good treatment for women who need it. Of course, the guidelines state that it's for women who have low libido, and so it's really important to get that information. Not many women would disclose that if they don't ask them. So yes, I prescribe testosterone to women who need it. Many women, I mean, the other day I had a lady who wanted testosterone, but didn't want HRT. And of course, that is not allowed on the guideline, partly because testosterone will end up getting metabolized into estrogen. So the way I describe it to women is like, if you have low estrogen, like you have a cup full of estrogen and you want to fill the other cup up with testosterone, basically testosterone just kind of empties itself to fill up the estrogen. So you're not going to have enough of the testosterone anyway. So we do need to optimize your estrogen levels. So for a lot of women, before I start them on testosterone, I always want to kind of, in a way, check if their estrogen levels are sufficient. And if not, I want to tweak that HRT first of all to see and make sure that we are getting sufficient doses of the estrogen. A number of people also think that testosterone is for weak muscles or tiredness, or, they're not really, or brain fog. And that is a little bit debatable. I would always stick to the guidelines and prefer to use it for what the guidelines states for low libido. But bearing in mind, not many women will be comfortable enough to discuss that. And then the other question is, what if a woman is not in a sexual relationship? How will she know that she has low libido? That can be a bit more tricky. And I would look at a number of different factors to help me consider that option of prescribing testosterone. But again, I think it's a good thing that we can now prescribe it. I remember being a GP 10, 15 years ago, we could not prescribe that at all. And we've gotten to a stage where we can help a lot of women who have the need for testosterone and HRT in a safe way. We can now do it better.
Any further questions before we bring the evening to a close? If you don't have any further questions, thank you so much for stepping in at short notice to present to us, and it's very much appreciated. We have a feedback form that Vicky has posted a link to, if you wouldn't mind completing that, those of you who have attended. And what we will do is we will send a copy of the slides. We will also send you a link to the recording and your CPD. But thank you ever so much, Jay, for this evening.
Thank you.
Thank you all for attending.
Thank you, everyone. It's lovely to have been here this evening, and send your regards to Verity as well.
I will do. Thank you ever so much, everybody, and have a good rest of your evening. Bye.